para darle paso a Hashim Ahmed. Trabaja en Londres, yo creo que ya ha salido varias veces citado en todos los artículos. La verdad es que cuando preparamos el programa no sabíamos que iba a sacar este artículo del 2017 justo antes de la reunión, ¿no? Yo creo que ha contestado un poco a la pregunta que hacíamos, porque en las guías, bueno, cuando tenemos una biopsia negativa y una elevación de PSA o sospecha de cáncer de próstata, bueno, pues está establecido que se puede hacer una resonancia. Vale, lo que es bueno para cuando ha fallado la anterior, ¿por qué no es bueno antes? Es la pregunta que nos hacíamos y es la que le habíamos dicho a Has que nos intentara contestar. Has, todo tuyo.
Thank you very much. Anders, thank you for inviting me. It's taken us 2 or 3 years for me to get here, so I apologize for the delay. And thank you all for having me here today. I apologize for not having sent the slides earlier for the interpreters as well, because I've been between institutions and trying to move to my new home. I'm going to talk about pre-biopsy MRI, and I'm going to focus on the PROMISE study, which you saw a couple of slides about from the previous 2 talks, but I'll go into more detail about this study. So I think, without doubt, this is the new pathway. Whether you as individuals and centers and healthcare systems can deliver this new pathway is a different question. The level 1 evidence demonstrates that this is the new pathway. The guidelines might take a while to catch up, but guidelines always are behind the level of evidence. Certainly up until 2016, the literature demonstrated that multiparametric MRI before biopsy improves our diagnostic ability to detect significant cancer and reduce detection of insignificant cancer. This is just one systematic review. You saw a lot of studies from the previous 2 studies, which demonstrates that there is a high sensitivity and a high negative predictive value. If we want to use MRI as a triage test to decide which men might be able to avoid a biopsy, then we need a high sensitivity and a high negative predictive value. Up until last year, there was a palpable lack of level 1 evidence. I will present one study that represents level 1 evidence. There have been others now, and there are about 3 or 4 which represent the highest levels of evidence. And certainly in the UK, our regulatory body, NICE, has launched an early review of its guidance in order to see whether they can update their guidance before the normal cycle. And anybody who sits on the EAU panel should probably think about this for the EAU guidelines as well. So the PROMISE study was run and sponsored by University College London, run by the MRC Clinical Trials Unit, and funded by the government. And we aimed to answer the question about whether MRI is able to identify a group of men that can avoid a biopsy, whether it can reduce overdiagnosis, and whether it can improve the detection of clinically significant cancers. And these objectives are deliberately in this order because we believe that these are the priorities, certainly at the time of conception of this study. So the trial was designed as a paired validating cohort study, so every man had everything. Everybody was blinded to all of the test results until right at the end. So a man with an elevated PSA up to 15, who would normally be recommended to have a trust biopsy, was invited to take part. They would have a 1.5 Tesla multiparametric MRI, And under general anesthetic, regardless of what the MRI showed, because none of us knew what the MRI showed, they would have the standard test, trust biopsy, and the template mapping biopsy as the reference standard. In this group of men, radical prostatectomy is not the reference standard. In this group of men, the majority of whom who do not have cancer, template mapping biopsy is the reference standard. And then all the results were revealed at the end. So the trust biopsy was a 12-core systematic biopsy compliant with international guidance, and every core was potted and reported individually, blind to the MRI results. The MRI was a 1.5 Tesla, no endorectal coil. We decided to deliberately exclude 3 Tesla MRIs from the study because most centers had 1.5 Tesla, and if it could perform well on a 1.5 Tesla magnet, then surely 3 Teslas would perform as well, if not slightly better. We had an independent company which looked at every single scan, which was to make sure that they were compliant with international guidance. And at the time that this study was conceived, it was before the PIRAD system, and so we used the Likert 1-5 scale. I'm not convinced there's that much difference in expert hands. And the positive MRI included the equivocal scans. So we included the ones where the radiologist was unsure as a positive in order to maximize sensitivity and maximize negative predictive value. Transperineal mapping biopsies were carried out every 5 millimeters, and if the prostate was long, then 2 biopsies were taken from each coordinate. And we carried on biopsying the whole prostate until the whole prostate was sampled. Now, some men couldn't undergo this biopsy strategy because they had huge glands above 100 cc, and therefore those men with a gland size of over 100 cc were systematically excluded. That, in my mind, takes away a lot of the negative prostates from this study. And that might explain why our prevalence of disease and significant disease was slightly higher than reported previously. We used a definition of significance that we felt everybody would agree with, although there is debate about whether this is the correct definition. So any man with 1 millimeter or more of Gleason 4+3 was significant, and any man with a cancer core length of 6 millimeters or more, whether it was grade 6, 7, or more, was also significant. The MRI was blinded to both the physicians, the researchers, and the patients. The biopsies were blinded to even the pathologists, as well as the patients. We had some withdrawals. Some men withdrew prior to knowing the results in order to know the result of the MRI. But that was a random chance as to whether they were positive or negative. And then there were some men who were systematically withdrawn because they had large prostates. We showed that MRI had higher sensitivity and negative predictive value than trust biopsy. But if your MRI was positive, then you still needed a biopsy because this test was not specific. And that was as a result of including all of the PIRADs or Likert 3s into the positive definition. So if we used MRI as a triage test to decide who could potentially avoid an immediate biopsy, you wouldn't necessarily discharge these men. You would still keep them under clinical surveillance. But who could avoid an immediate biopsy? What sort of cancers would we miss? So these are the 2 groups we're interested in. The scores of MRI 1 and 2, where there was still significant cancer on the mapping biopsy. Trust biopsy would miss significantly more high-volume Gleason 7 cancers. Trust biopsy would miss significantly more high-volume Gleason 3+4 cancers. MRI would miss no dominant pattern 4 Gleason 7 cancers or more. So there are a number of questions around this study, legitimate questions. So is the promised definition the correct one? Our definition for clinical significance over the last decade has been rising. STAMI started with 0.2 milliliters, it's gone up to 0.5, and in the European screening study, their microsimulation by Walters et al. 2 or 3 years ago showed that if you have pure Gleason 6, then any lesion with a volume of less than 1.3 ml is insignificant. That's a big tumor. That's about 9 to 12 millimeters of Gleason 6. On biopsy as well, the number of millimeters of cancer that we accept as clinically significant has gone up. 2 millimeters, 3, we used 6. The Swedish Cancer Registry says it should be 8. And in the UK, the NICE guidance says 10. We also know that not all Gleason 7s behave in the same way. The amount of pattern 4 is very important. These are 2 studies from the European screening study, 2 centers, which carried out active surveillance in men with intermediate risk disease, and they found no difference in survival, albeit in the medium term between intermediate and low risk cases on active surveillance. We also know the amount of pattern 4 on radical prostatectomy can be predictive of failure after treatment. These are 3 studies, all showing the same thing, that the amount of pattern 4 predicts failure after radical prostatectomy. And this is another study that shows there is a difference between Gleason 6 and 3+4 in terms of predicting mortality, but there's a big difference between Gleason 4+3 and 3+4. So the big question going forward is how much pattern 4 in Gleason 3+4 tumors can we accept? And I don't have the answer to that yet. We won't get an answer because we have been reliant on this completely inaccurate transrectal biopsy to guide all of our risk predictive models. We are going to have to start all over again. All of the studies that used trust biopsy have to be dumped, and we have to start again in developing new risk prediction models based on targeted biopsies, which can characterize the tumor much more accurately. So is it legitimate to not biopsy men with a negative or a non-suspicious MRI? If we're really serious about overcoming the 1 in 10 miss rate of multiparametric MRI for clinically significant cancer, then you shouldn't be using a test which is rubbish after a really good test. When that rubbish test has a miss rate of 1 in 3, it just doesn't make logical sense. If you're really serious about overcoming the miss rate, you're going to have to do template mapping biopsies in tens of thousands of men. And that's not feasible. So this is a study where we carried out targeted biopsies as well as mapping biopsies in about 400 men. And we found roughly the same number of significant cancers with targeted biopsies as mapping biopsy, although the template mapping biopsies picked up slightly more cancers. We know that. But by doing template mapping biopsies, you pick up huge numbers of additional clinically insignificant cancers that shouldn't be diagnosed and those men are going to have the anxiety and the morbidity, and some of my colleagues will misbehave and treat these men unnecessarily and cause them harm. And there is a big cost issue with biopsying in this way. In the UK, it would cost us £250 million every year to biopsy men with mapping biopsies. This strategy is not the way forward. We are all used to not having diagnostic tests which are not 100%. Over the last 3 decades, we have all been using a biopsy test, a diagnostic test, which is only 48% sensitive. And yet we are now concerned about a diagnostic test that is 93% sensitive. It doesn't make sense. We do have a problem in that not everybody is capable of doing it, and this is a big problem that the radiological fraternity is going to have to get a hold of, and we as a urological community are going to have to be engaged in that as well. In mammography, because there are screening programs, these are laid down in law. So we have to have quality assurance guidelines mandatory for every single radiologist to abide by. And there are set parameters. If you report your mammograms with too high a positive rate, you will be brought in front of the committee. If you underreport your mammograms compared to your colleagues, you will be brought back for training. If your biopsies are missing cancers compared to your colleagues, you will be brought back for training. It's mandatory. So we're going to have to start thinking along these similar routes, because otherwise there will be chaos. So we will need accreditation, we will need quality control, we will need to start looking at outliers, and we will need to start sharing best practice. And that's the only way we're going to be able to deliver this new diagnostic modality. Is MRI before biopsy cost effective? There are a number of studies that show it is. This study showed that the incorporation of MRI and MRI-targeted biopsy in prostate cancer diagnosis and management represents a cost-effective measure at 5, 10, 15, and 20 years after initial diagnosis. This other study shows that MRI is cost-effective at a willingness to pay value of 1,000 euros per quali. That's quite cheap. For drugs, we are willing to pay 23,000, 25,000, 30,000 euros per quali. And these are all the simulations that they carry out, and most of the simulations and models show that MRI is more effective, although it is fairly split between being more expensive or less expensive. Overall, the model shows with the orange rhomboid in the middle that MRI is more effective and slightly more expensive. So you have to invest. So in conclusion, trust biopsy has poor attributes for a diagnostic test. MRI prior to trust biopsy can identify at least 1/4 of men presenting with an elevated PSA who might safely avoid prostate biopsies. Multiparametric MRI using at least a 1.5 Tesla magnet followed by biopsy can reduce overdiagnosis of clinically unimportant cancers and improve the diagnosis of important cancers. Almost double the detection compared to trust biopsy. You saw Ande's results in a clinical setting. And an MPMRI before biopsy strategy is clinically and cost-effective and should now be the new standard of care before a first biopsy. Thank you very much.
Bien.